So hello, my name is Mahnoor Khan, and I'm a medical student in Michigan State College of Human Medicine, and I'll be presenting on the topic of treatment of sickle cell crisis in a pregnant patient complicated by multiple associated comorbidities. So to introduce the topic, sickle cell disease or SCD is an inherited hemoglobinopathy present in 8% of the African American population. And in pregnant patients, SCD can cause debilitating pain for the patient and increase fetal mortality risk. Pregnancy in response to sickle cell crisis exacerbates the hemolytic condition in sickle cell disease. So pregnancy can induce anemia, hypercoagulability, hyperviscosity, and predispose patients to high-risk complications like sickle cell crisis, including acute chest pain syndrome, avascular necrosis, thrombotic events, and vasculo-occlusive crises, or VOC. And VOC is an important response to SCD because it occurs when sickle cell red blood cells attach to the endothelium and cause occlusions, which causes severe pain and tissue ischemia. And this commonly occurs in 50% of pregnant patients with SCD and increases pregnancy risks such as preeclampsia, infection, maternal thrombosis, preterm labor, and fetal malformations and prematurity. Furthermore, SCD and pregnancy are complicated by the compromised immune system. So in sickle cell disease, autosplenectomy is often conducted, which exacerbates the immunocompromised state of pregnancy, increasing susceptibility to infection inside its sickle cell crisis. So to address the causative issues, hydroxyurea and blood transfusions are used as a mainstay treatment for reducing the frequency and managing SCD crises. While guidelines suggest hydroxyurea is safe in the second trimester, clinical judgment may be used to weigh the benefit during pregnancy against its risk of teratogenic concerns. And I'll talk about that a little bit more in the background section when I get to the treatment options. Also, another treatment are simple and exchange transfusions, which are used for management of SCD in pregnancy and are indicated based on crisis severity, patient history, and risk of complications. So the goal of this case study is to explore the therapeutic challenges faced when managing a high-risk pregnant patient in sickle cell crises with beta thalassemia minor to improve maternal and fetal health outcomes. So if you look at the figure, the diagram shows the overview of the etiology, complications, diagnosis, and treatment of sickle cell disease. And it's caused by mutations that cause abnormal hemoglobin S, which when deoxygenated polymerizes and reduces the abnormal sickling of red blood cells, which obstructs blood flow and causes microvascular occlusions leading to tissue ischemia, as I mentioned earlier. Sickle cell also has many genetic variants, including sickle cell beta thalassemia, which includes altered beta globin chains. In our patient, a patient has sickle cell beta thalassemia minor, which typically presents asymptomatically due to the partially altered beta globin function, but can cause chronic anemia. Sickle cell can be diagnosed with hemoglobin electrophoresis, and we have that here for our patient in the first table. And I'll go over that in a little bit. And we can also use peripheral blood smears and genetic testing. So we are focusing here on the treatment protocol for a patient who's pregnant and has sickle cell crisis. The treatment protocol typically addresses vaso-occlusive crises by implementing a multifaceted approach aimed at pain control, hydration, hemoglobin maintenance, and supportive care, in addition to addressing any precipitating factors such as infections. So a few of the important things we would target are we would use prenatal counseling and preconception planning as important proactive management strategies. Pain control is often addressed using NSAIDs or opioids, depending on the intensity of pain. Prenatal vitamins like folate are used to decrease gestational risks and increase erythropoiesis. And prophylactic antibiotics are used to address infections during crises or infections that cause a crisis. But as mentioned earlier, the mainstay treatments for SCD and pregnancy are hydroxyurea and blood transfusions, and I'll talk about that now. You can refer to the bottom left section of in the background. So hydroxyurea is used for long-term management of SCD because it reduces the frequency of sickle cell crises and reduces disease-related complications. Its mechanism is that it increases fetal hemoglobin F, which reduces the polymerization of hemoglobin S, improving the oxygen carrying capacity and reduces the sickling of erythrocytes. However, it is highly contraindicated in pregnancy, particularly during the organogenesis period of gestation, which is 3 to 8 weeks. And this is because it's an anti-neoplastic drug that inhibits the ribonucleotide reductase, blocking the formation of deoxynucleotides for DNA. So hydroxyurea has been known to cause congenital abnormalities, prematurity, and increased risk of miscarriages and stillbirths. But there are many guidelines out there regarding the use of hydroxyurea. Typically, they say that hydroxyurea is safe to use past the organogenesis period in the second trimester, but it should be discontinued during the organogenesis period. But ultimately, the decision should be made through shared decision making with clinicians and patients while taking into account the severity of the SCD crisis, the level of pain, baseline hemoglobin levels, and previous pregnancy statuses. The other option that is often also used conjunctively is blood transfusions for acute and prophylactic treatment. And the way that they work is they decrease the proportion of hemoglobin S to hemoglobin A and increase oxygen delivering capacity of red blood cells to manage vaso-occlusive crises complications. And it's a common strategy used to decrease hemoglobin S when patients are taken off of hydroxyurea and can't increase their own hemoglobin F levels. So there's two types. There's simple transfusion, which infuses donor blood without removing the patient's own blood. And this increases the normal number of red blood cells, diluting the sickle cell numbers and improving oxygen delivery capacity. But the risks associated are hyperviscosity and iron overload. Exchange transfusions replace a patient's sickle cells with the donor blood, which reduces hemoglobin S and improves the red blood cell oxygen carrying capacity and decreases blood viscosity. But some concerns there are alloimmunization, iron overload, and thrombosis. So guidelines typically indicate simple transfusion and exchange transfusion, just depending on the risk and benefits of each intervention in response to the condition of the mother and the level of crises. Typically, exchange transfusions are indicated over simple transfusion because they're more effective at lowering the concentration of hemoglobin S while minimizing the risk of hyperviscosity, which can occur with simple transfusions. However, there are many reasons why simple transfusion might be chosen over exchange. For example, there's a mild to moderate crisis level, how well crises have been managed in the patient in the past. And for example, if a patient is severely anemic and needs an immediate increase in hemoglobin, then a simple transfusion might be preferred because it's quicker at increasing their oxygen carrying capacity compared to exchange transfusions. So with this background in mind, I'll tell you about our patient. Our patient is a 35-year-old African-American G4P3003 at 16 weeks pregnant, female with a past medical history of sickle cell beta thalassemia, osteoarthritis, avascular necrosis, and deep vein thrombosis, presenting with third sickle cell crisis with diffuse arthralgias and chest pain. Her course was further complicated by unrelenting shoulder pain and positive chlamydia and gonorrhea test, which was likely that inciting factor for the SCD crisis. So as mentioned earlier, hemoglobin electrophoresis is often used to diagnose the specific genotype of sickle cell. And in this case, patient was confirmed to have sickle cell beta thalassemia due to increased hemoglobin levels and severely increased hemoglobin S levels. And those are both for sickle cell and beta thalassemia. And then the graph below that shows the patient's white blood cells and hemoglobin levels during her inpatient care. You can see that her white blood cells were elevated when she was initially admitted, indicating that her sickle cell crisis was likely secondary to infections of chlamydia and gonorrhea, but then it returned to baseline following antibiotic therapy. Her hemoglobin levels also were trending below the goal level of 8 milligrams per deciliter at admittance, but through the course of treatment, her hemoglobin levels were returned back to baseline level. So regarding the treatment that was decided on this particular patient, she was given IV fluids and opioids for pain control and folate and aspirin to decrease risk of gestational complications. And for simple and exchange transfusions, they were evaluated for her hemoglobin maintenance above 8 milligrams per deciliter. In this patient, simple transfusion was chosen based on her symptoms, level of SCD crisis, and to allow for rapid stabilization of her hemoglobin levels and symptom relief. We also took into account that she had 3 previous pregnancies that had normal courses with vaginal births, indicating effective management of her condition and decreased risk of complications if we chose simple over exchange. While there is concern for dilutional anemia with simple transfusions, that could also be attributed to the nature of pregnancy. And finally, exchange would have been considered if she was on the program prenatally or prophylactically for a C-section. But there's always concern that hemoglobin might be dropping too low with exchange transfusions, leading to inadequate oxygen delivery. And hydroxyurea was also offered to curb the crisis to determine the significant, or after determining significant risk of hemolysis from transfusions. But the patient actually declined herself because she was aware of the teratogenic effects of hydroxyurea, and she did not feel that it was safe for her pregnancy and her fetus. But with ongoing outpatient monitoring, the patient might be recommended to return to hydroxyurea since she is past organogenesis period and is well beyond her second trimester. So in conclusion, this study was exploring the therapeutic challenges when managing a high-risk pregnant patient in sickle cell crisis, and what things you need to consider when you are trying to maximize maternal and fetal health outcomes. So a few things that are of note in this case study is that due to the ongoing sickle cell crisis, her level of pain and pregnancy, the transition back home was prolonged for the patient past typical SCD treatment courses, illustrating the complex interaction with pregnancy and sickle cell. However, it was difficult to figure out a treatment plan because there's limited research available in SCD crisis management in pregnancy, and especially because many of the medications used for SCD management pose significant risks for the fetus and mother in pregnancy. So clinicians must consider patient-specific factors, clinical factors when determining treatment. One of the most important things for management is for effective communication, interdisciplinary communication between different care teams, including OB-GYN, maternal fetal medicine, and hematology teams to develop an individualized treatment plan. One of the strategies that you can use is implementing prenatal care and prenatal counseling to initiate proactive management strategies for sickle cell crisis and pregnancy. And finally, while SCD itself makes for a complex treatment in pregnancy, further research into treatment options such as the safety of hydroxyurea and appropriate indications for simple exchange transfusions are warranted to assist in the medical decision making to ultimately decrease the frequency of SCD crisis in pregnancy. Thank you.